May I have your attention, please? Good afternoon. So, all dental people maintain silence because otherwise we will eat up into your time. Thank you. Just kidding. Okay. So, we are going to present today a case which was not only a diagnostic challenge, it was a rare entity, but it was also a therapeutic dilemma whether to treat, not to treat, how aggressively treat, and it also highlights the limitations of the modern medicine, helplessness many a times. So we start with.
Good afternoon, everyone. Today I'll be presenting clinical combined rounds on the topic Chasing Shadows, Delayed Diagnosis of Peripheral T-cell Lymphoma. So, a 50-year-old male resident of Nepal presented with chief complaints of erythematous scaly plaques of varying severity since last 5 years, non-significant weight loss of 3 to 5 kg in last 1 year, gradual swelling of face, generalized erythema and skin thickening since last 6 months. He had low-grade fever since last 4 months and ulceration, spontaneous ulceration over his tip of nose since last 1 month. The course of the disease is as follows. He started developing erythematous scaly plaques over his back, and within next 2 years, it progressed to involve his other areas, and there were no site predilections according to the history. A skin biopsy was done in 2018, which was suggestive of prurigo simplex. And every time he had significant response with prednisolone and other steroids, but there was recurrence on stopping the treatment. He landed up in erythroderma in October 2022, and he came to us. At that time, we made a diagnosis of erythroderma secondary to atopic dermatitis in view of flexural accentuation of the lesions on examination, family history of asthma in his mother, and a spongiotic tissue reaction in his biopsy. These are the clinical photographs of the patient in 2022 when he landed up in erythroderma. He had generalized skin thickening, swelling of the face, and scaly papuloplaques over his body. In the ward, he was started on prednisolone 30 milligram, with which he had significant response. But during admission itself, tapering the prednisolone to 20 milligram, there was a flare. So he was started on cyclosporine, and he was discharged with cyclosporine 250 milligram, prednisolone 15 milligram per day, with which his disease was well controlled. But within next 2 to 3 months, his cyclosporine has to be discontinued in view of hypertension. And he was started on tofacitinib 10 milligram per day, with which he had around 70 to 80% control in next 2 months. This treatment was started from teledermatology. But in view of partial response, he shifted to alternate medication for 6 months, after which he landed up in flare with diffuse infiltration of face, spontaneous ulceration, and the complaints with which he presented, like non-significant weight loss of 3 to 5 kg, gradual swelling of the face, etc. Biopsy was done in Nepal Government Medical College, which showed features of chronic actinic reticuloid. Mainly, it showed spongiotic tissue reaction, but few cells were enlarged with irregular convoluted nuclei, and atypical mitosis and Pottier's microabscess was also present. So they made a possibility of cutaneous T-cell lymphoma has to be ruled out. The IHC showed 50 to 60% cells were CD3 positive, and most of the CD3 positive cells showed a loss of CD4, 8, 7, and PD1, and he was referred again to AIIMS. He came to us in December 2023, and on general examination, he was febrile. There was no pallor, icterus, cyanosis, or clubbing. He had bilateral enlarged inguinal lymph nodes, which were multiple, oval, discrete, 3 to 2 centimeter, oval, firm, and non-tender. He had bilateral pitting pedal edema. His blood pressure and heart rate were within normal limits, and there was no organomegaly. On mucocutaneous examination, his face, scalp, trunk, and bilateral extremities were covered with fine scaling on a background of erythema with swelling and infiltrations, predominantly over his face with oozing. He has fissures over his bilateral shoulders and diffuse alopecia. His palm and soles were involved in the form of scaling, almost keratoderma-like, which were punctate over his palms and confluent over his soles. His nails were dystrophic with thickening of the nail plate. These are the clinical images of the picture of the patient when he was admitted in December 2023. He had generalized skin thickening, scaling with oozing from his lesions, swelling over his face, and fissures over his shoulder. These are his baseline investigations. Almost all his investigations are within normal limits, except eosinophilia during admission, which improved in next 1 month. His peripheral smear showed no atypical cells on repeated investigations. LDH was just slightly raised. His slit skin smear from bilateral earlobe was negative. Flow cytometer didn't show any criminal T cells, and bone marrow aspirate, there was no evidence of lymphoma, and the sample was not adequate for biopsy. His PET CT showed metabolically active generalized skin thickening with bilateral cervical, axillary, paracable, pelvic, and inguinal lymph node, likely MF. The patient was when the patient was admitted, he was febrile. He was having high grade fever, but he became afebrile with 2 days of injection peptides. There was some improvement with prednisolone 40 milligram in 1 week, followed by there was no further response. And he started developing spontaneous non-healing ulcerations over his face with pus discharge. Multiple times pulse culture has been sent, which showed multiple organisms, initially morgagni, MRSA, Acinetobacter and accordingly the antibiotics were changed, but there was no response in the non-healing ulcers. These are the clinical photographs of the patient after 1 month of tablet Vicelon 40 milligram for 1 month. He started developing the spontaneous ulceration. He started developing this spontaneous ulceration, and there was minimal difference from the baseline in the swelling of his face.
Good afternoon. We have multiple biopsies of this patient, but I could able to retrieve those biopsies which are recently one and reported by me, the lymphoma. There are the 2 skin biopsies, 1 lymph node biopsies. The initial skin biopsies we can see here, almost thinning out of the epidermis, few irregular acanthosis, and there is pandermal diffuse infiltration by the lymphoid cells. And if you go to, these are almost intermediate size lymphoid cells. And one interesting finding is there's no epidermotropism as such. There's no epidermotropism. On immunohistochemistry, they are diffusely positive for CD3. With the scanner view, you can see they are negative for 20, and there is a higher power, which shows there's a CD3 positive, and as by the previous biopsy report from Nepal, the similar, there's a double negative population. They're all negative for 4 and 8. They are positive for 5 or negative for 7. If you interpret these IHCs, so loss of anti-cell marker, loss of both 3, 4 and 8, it indicates T-cell lymphomas. Then subsequently, we received the inguinal lymph node biopsy because there is some in discussion. The clinicians are not happy with the diagnosis of lymphoma because there are other things. Then they give this lymph node biopsies. So there's again the complete effaced architecture. And if you go to high power, it is a polymorphous population which comprises both these atypical lymphoid cells and the few eosinophils and histiocytes and many high endothelial venules. These morphological features again indicate possibility of a T-cell lymphoma. And the IHC markers are almost similar as we see in case of the skin biopsy. So we thought it is either a mycosis which is involving lymph node or a petechial which is involving either way around. But as there is a predominant skin lesions, probably a mycosis involving the lymph nodes. But the odd point is there is no at all this epidermotropism, which can sometimes happen also. So due to lots of confusion, whether it is a lymphoma or not lymphoma, then I try to do this TCR gene rearrangement assay. So what we do exactly in TCR gene rearrangement assay, if it is a clonal population, if you can see a single clonal peak. So these are the controls which you can see there is a Gaussian distribution, there is a polyclonal population. To interpret this, each single peak is a one T cell clone. So if it is a polyclonal, then it gives a Gaussian distribution. But here it is a clonal control in a background of polyclonal. So these are the 2 cases. If you see our case, it is a single peak, and very interesting finding, if you see, it's almost the same around 280 base pair. So this indicates if the peaks are in the same area. This is the same clone which present in the skin, which is again the same clone which present inside the lymph node. So indicating there's the same population of T cells, probably lymphomatous population, which involving both the areas. If you say all clonal T cell in the skin are lymphoma, not always, but in this scenario, but all lymphomas are clonal. That's sure. Because many atopic cases may give rise to sometimes a clonality, but they never involves this kind of generalized lymph node involvement. So these are, if you see individual plots, again the same thing, clonal population. Again, after the treatment, again these two biopsies are in 2023. Then 24 again the repeat biopsy to see the response assessment. But I couldn't find any the similar again pictures. None of these things showing too much of spongiosis or any epidermotropism. But again, pandermal infiltration, the similar as we see in the previous the biopsies 2 or 3 months back, and similar features. So we didn't do too much of IHCs here because it's already proven that it's a peripheral T cell lymphoma, and then to show whether it is a mycosis with a CGRE, but as the peripheral blood, there is not at all a single clonal population in atypical cell. So we call it either a mycosis, which is involving node, or there is a peripheral T cell lymphoma, NOS of the skin. So it's all clinical correlation to finalize things, but anyway, it is a peripheral T cell lymphoma. Thank you.
Good afternoon, everyone. The F18 FDG PET-CT study was done on 7th December 2023. This is the maximum intensity projection image showing diffuse skin uptake in the generalized entire body, and different parts are showing the CT and fused PET-CT images showing lymph nodes in the submental region. Then in the left, level 5 cervical lymph node, then bilateral axillary lymph nodes, then the paracaval lymph node, then bilateral common iliac lymph node area, then bilateral external iliac region, then in bilateral inguinofemoral region. The overall generalized lymphadenopathy is more likely suggesting mycosis fungoides is more likely.
So the final diagnosis was made erythroderma secondary to PTCL and not otherwise specified.
So with this diagnosis, the patient was referred to the medical oncology department. A staging PET was showing diffuse lymphadenopathy. There was a diffuse skin involvement also with erythroderma involving more than 90% of the body surface area. So the patient was staged as a stage 4A disease, and further he was planned to receive chemotherapy. Plan was to give 3 cycles of CHOP, and then followed by response assessment was planned. So the patient was given cycle 1 of CHOP therapy, which contains cyclophosphamide, daunorubicin, vincristine, and prednisolone, with effect from 17th of January. But the patient continued to have discharge from the skin lesions. So after CHOP therapy, the patient developed febrile neutropenia. He had a TLC count of 880 and ANC of 350, and he was febrile. So patient was started on empirical antibiotics. He was given injection cefoperazone sulbactam, that is Magnex, and injection amikacin. And keeping the skin as a possible source, the teicoplanin was also added. Patient blood culture and urine cultures were sent. Further, on evaluation, patient became afebrile for a few days, but then again started to have fever. So the TLC improved, but patient was still febrile. So further, the fever workup was sent, and antibiotics were changed because he was not showing response to the previous antibiotics. So antibiotics were changed to meropenem and linezolid. And throughout, one thing to note was that patient always had a poor nutritional status with the total protein of 5.8 and albumin was around 2.3 and then 1.4. So fever workup was sent. All the blood cultures were sent. They were sterile. And only thing was that procalcitonin was raised, which was suggesting that some sort of sepsis is there. And we sent the stool routine examination, that was normal, urine routine, urine culture. Then atypical infections were also ruled out, like scrub typhus was negative. Then dengue, malaria, and Vidal test was also negative. So actually, we were thinking that whether it is a disease or it is infection. So as the procalcitonin was high, it was pointing more towards infection. So further, imaging studies were done. Chest X-ray was done, that was normal. USG abdomen and pelvis to rule out any abscess formation was done. It was also normal. Then HRCT was planned. HRCT showed multiple centrilobular soft tissue densities within bilateral lung fields, suggestive of active endobronchial infection.
These are the images from the non-contrast chest CD that was done on 8th of February. And in the first image, we can see that is the mediastinal window. And we can see that there are bilateral enlarged axillary lymph nodes, which are showing loss of architecture and loss of fatty hilum. The second image also shows the same finding with the yellow arrow. In the third image and the fourth image, we can see that there are part solid, part ground glass opacity nodule that are seen in the left upper lobe and the right lower lobe. So these are the finding of, next slide. Yeah, so the finding of axillary lymph nodes is consistent with the lymphoma, lymphomatous involvement, while the nodules that are seen in the bilateral lung fields are suggestive of a superimposed infection, which is non-specific, can be fungal or viral.
So further, to see what kind of infection it is, a bronchoalveolar lavage was planned. Bile culture was negative. While galactomannan was borderline. It was 1.03. The ZN stain was negative, and the gene expert came out to be indeterminate. So patient was started on ATT. Then further, the cultures showed that from the skin lesion, as the skin lesions persisted and there was pus discharge from skin, the pus culture was sent and it showed Acinetobacter, which was carbapenem resistant and was sensitive only to piperacillin tazobactam and tigecycline. And further, the blood culture also showed a similar Acinetobacter carbapenem resistant bacteria, which was sensitive only to colistin and minocycline. So accordingly, the antibiotics were added. But this patient continued to worsen. Initially, he became afebrile, but then he developed hypothermia, which again can be an indicator of sepsis. Further, he had a very poor nutritional status, was not taking anything orally. He had a poor nutrition, so Rialsu was inserted and he was started on enteral feeding, and IV albumin was also started. Patient continued to worsen, had sepsis, then developed shock and had a new onset respiratory distress also. So he finally he succumbed to death. So we made a final diagnosis of extranodal PTCL NOS, stage 4A. He was given cycle 1 CHOP. He had sepsis due to Acinetobacter with refractory septic shock.
Now for review of literature. Peripheral T-cell lymphomas, they are heterogeneous group of lymphoproliferative disorders arising from the mature T cells. And we will be discussing about peripheral T-cell lymphomas, not otherwise specified. So they are not corresponding to any of the defined T-cell entities, and the skin and subcutaneous involvement is approximately 20% in these cases. It's a diagnosis of exclusion, and the median age of diagnosis is 60 years, and male-female ratio 1.9 to 2:1. Here we can see the WHO URTC classification 2018. We can see the primary cutaneous peripheral T-cell lymphoma, the frequency to be 2% when compared with MF, Mycosis fungoides, which is the most common, like 39%. And also the 5-year disease survival, we can see that in MF it is 88% compared to primary cutaneous peripheral T-cell lymphoma, not otherwise specified, which is 15%. showing the rarity of the condition and also the reduced 5-year disease survival rate. What is the delay in the diagnosis of the condition according with skin lesions? We can see that in a case series done by Becken et al. In 2003, the duration of skin lesion prior to the diagnosis varied from 1 month to 8 years. And similarly, other studies also showed that there is a delay in diagnosis that is varying from 1 to 18 months, where the median being 6 to 6 months, and also there is a 53% increased risk of death per year. And regarding the cutaneous manifestation of peripheral T-cell lymphoma not otherwise specified, so it varies from patient to patient and also within patient. So it can either present as indurated plaques or nodules, which we can see in this picture, or as necrotic ulcers, tumor-like nodules, or as just faint eruptions, or even like disfiguring facial swellings and cellulitis. So here we have the largest case series says that most of the lesions were nodules and tumors, and 61% of the cases were multifocal. And also in a case series by Vellet et al., it was seen that in the extranodal involvement, the skin involvement was more common, that is 33% compared to bone marrow and lung involvement. So this was our patient. So he had, he presented to us in erythroderma, and also he had these ulcerated nodules over the face and also leonine facies. So the initial diagnosis were made was prurigo simplex, erythroderma. When he presented to us in 2022, the erythroderma secondary to atopic dermatitis, erythroderma secondary to chronic actinic dermatitis, and chorymycosis fungoides. So this is another study which shows that intractable eczematous lesions could be the manifestations of cutaneous dissemination from nodal lymphoma, and PTCL, not otherwise specified, is likely associated with this cutaneous morphology. So out of 425 cases, 8 cases of PTCL NOS were selected and were present, and out of these 8 cases, 4 were having intractable eczematous lesions. And regarding the histopathology, as we have already discussed, the epidermotropism is usually mild and absent, and there is variable immunophenotype showing absence of CD4 and variable loss of all the other T-cell antigens. Then going to the treatment modalities, we will be discussing about few treatment modalities, and the first line according to the latest oncology guidelines are the anthracycline-based chemotherapy, the CHOP multi-agent regime, which can increase the survival to 40 to 60% within a period of 2 years. And there is no definitive study for hematopoietic stem cell transplantation as a first line for consolidation, refractory or relapsed disease. And this is an Echelon 2 trial where brentuximab vedotin was combined with CHP, and it is approved by FDA as a first-line therapy for patients with PTCL NOS, because in comparison with CHOP, where there is an increased survival to 60%, here there was an increased overall survival to 70%. The other single agents which are also used include romidepsin, bendamustine, pralatrexate, etc. So even with systemic chemotherapy and stem cell transplantation, the prognosis of peripheral T-cell lymphoma, cutaneous T-cell lymphoma not otherwise specified, is very poor. So here we can see this was done for making a prognostic model from, and this was a retrospective multicentric clinical trial study where there were various treatments given to the patient. So we can see the treatments like 7 patients there were no chemotherapy, others were given chemotherapy and with anthracycline, without anthracycline, and also some were given high dose chemotherapy followed by hematopoietic stem cell transplantation. But they didn't compare between the groups in the overall survival, but the cumulative probability of survival in 5 years was found to be 43%. And this is another complete registry for lymphoma where almost 499 patients were selected, and they compared the relapsed cases and refractive cases by giving them they compared the relapsed cases and the refractive cases. So there were 74 relapsed cases and 53 refractory cases. And it was found that most of the relapse cases received single agent because they were second line, and the combination chemotherapy was received by refractory cases. But it was also seen that at the end that the overall response rate and the overall survival was more in relapse cases who received single agent than compared to refractory cases who were receiving combination therapy, maybe due to the toxicity of the combination therapy. And regarding the prognosis, the independent predictors of disease survival was found to be, decreased survival was found to be age, which is more than 60 years, the Eastern Cooperative Oncology Group performance status more than or equal to 2, high levels of LDH, and involvement of bone marrow. The 5-year overall survival rate was found to be 33% in the presence of 2 risk factors and 18% in the presence of 3 or 4 risk factors. This is another case that we have seen recently, a 21-year-old female with a total duration of 3 years. She was also having intractable eczematous-like lesions, prurigo lesions, and her skin biopsy was also suggestive of prurigo simplex. Her PET CT was done, and also it was seen that she had a group of lymph nodes enlarged in the inguinal region, and lymph node biopsy was suggestive of atypical lymphoid proliferation, and her IHCs and T cell rearrangement is awaited. We don't know if it can also turn out to be another PTCL or just an incidental finding. Thank you. And now the topic is open for discussion.
Then to decide on the treatment, whether to go for CHOP or not to go for CHOP on us. So that situation is even worse because then onus is on us whether to go ahead with the regime or the patient had another few years. But eventually, I think most of these patients, they succumb to death. It is open for discussion.
Diagnosis in your case, median delay in the diagnosis in your case?
5 years.
It was relatively more compared to the literature. I think this patient did not follow the usual course of the disease which we read in the book, and probably that's why, Dr. Somya, there was a hesitancy from the clinician side to accept the diagnosis of T-cell lymphoma, because the initial course was very slow and indolent, and there was a sudden downfall of the disease, very rapid progression, ulceration, and that's the time we could catch the diagnosis.
Yeah, so initial skin biopsies were not reported as lymphoma, but they raised a suspicion of lymphoproliferative disorders, but they were not confirmatory of lymphoma. So that was more a reason. And the response to initial treatment was excellent. When he came to us in 2018 with prurigo-like lesions, the response was really good. Even in 2022, he responded to treatment but relapsed. So that's the thing.
Yeah, I think the behavior of these tumors and these diseases is very unpredictable. Sometimes they can remain dormant for many years, and the average in some reports have shown that it has taken up to 10 years before the diagnosis could be made, and sometimes once they reach to that stage, then there could be a rapid progression. So which is what seems to have happened in our case also. I wanted to ask a question from the nuclear medicine team. That is, how easy is it to differentiate between the malignant and the inflammatory lesion?
Inflammatory lymph nodes, they show maintained hilum normally. Malignants are rounded cells. No other clue. The histopath is confirmatory actually.
So on this, you could easily say that this is...
This is rounded lymph node. Loss of fatty hilum is there.
Okay. Thank you.
Just regarding the review, I think we have the largest series regarding the frequency. The epidemiology of lymphoma is from our department is 4,500 cases. Even one study from CMC, equivalent case of 3,500. We can show what is in our context the PTCLs. The two largest weapon from our own department. So usually we show our AIIMS data. You can, so it's okay. There's the AS paper and the international T-cell group, but we have also our Indian data to show how many cases of PTC.
500.
It is the one of the largest
in the world. Yeah.
epidemiological data of lymphomas from AIIMS. Yes, sir, published.
Residents,
Even sir, CMC Vellore study also approximately
comments
4,000 cases of epidemiology of lymphomas.
residents, any comments? Yeah. Right. Yeah.
If a patient has a refractory prurigo or endogenous dermatitis, should we get a PET scan done for the patient? Like after how long? Because we got it done for another patient, even though she did not have any other.
That's a very difficult question because at that time, patient didn't have even any slightest clinical suspicion of lymphoma. So I think we have to raise our level of suspicion in any case who comes with, all recalcitrant or unresponsive, or where the histopathology is slightly suggestive. His second histopathology in 2022 was suggestive of chronic actinic dermatitis to rule out lymphoma. That was the missing point, I guess. At that time, we should have been little more suspicious. But that's a good question. Vishal, anything?
In skin, it is a different scenario from the lymph node. If it is a lymph node, it is a clonal population. Probably, if it is a immunocompetent patient, it is a lymphoma. But then skin, it is said that even if you find a clonal population, don't call a lymphoma unless until your clinician is saying lymphoma. So that's why you don't do usually TCR rearrangement for the your mycosis fungoidosis. If you say lymphoma, then we will say lymphoma. Even if we find a clonal population, we will not call lymphoma unless until clinician says it's a lymphoma.
More like a clinician's failure, because if we start treatment in the early stage, the chances of survival are slightly better. Stage 1 and 2. Yeah.
Just a couple of points. We think that probably the earlier dermatitis was not dermatitis and that was lymphoma to begin with, that was missed, right, sir?
Yeah, that's a possible. So in literature, they say that psoriasis and atopic dermatitis prevalence is much more common in peripheral T-cell lymphoma as compared to normal population.
Right. Is it possible that the immunosuppressive treatments that the patient had received, including JAK inhibitors, that could have led to a secondary malignancy? And my second question is, how was mycosis fungoides excluded? Because the pathologist had kept both the differentials, mycosis fungoides as well as PTCL loss.
Like if you say it is a cause or effect, like skin lesion, it is very difficult to say. But as per the lymphoma, we see if it is a PTCL of lymph node secondary causing skin lesions, so the patient could have survived from 18 to 21 because PTCLs are very aggressive lymphomas. Whatever you do, it is very, except few decimal. So if you hypothesize, probably it is a skin conditions which lead to repeated stimulation which finally transform to a malignant condition. That could be what I can feel, probably a skin condition which later turned to be a malignancy.
No, that's why I asked this question. Could it actually have been some very unusual aggressive form of mycosis fungoides? Because that's how it behaves. It remains indolent for a very long period of time. It gets misdiagnosed as other benign conditions. And it can be advanced stage like we are seeing in this particular case. So is there any conclusive point in this particular case which excludes mycosis fungoides?
That's, I think, the clinical side can say whether this type of presentation can mycosis present or not. From our side, if you say this is a lymphoma, the peripheral biopsies are also lymphoma.
It would still be very difficult for the clinician also to say, because many times that the disease continues to remain undifferentiated. You can't make a diagnosis. It just goes on dermatitis for years together.
Yeah, so it's very difficult, but I think in 2022 it was quite lymphoma, because even in histopathology it was suggested. Or versus, that is very difficult. I had a discussion with him in the morning and he said that it is the ball is in clinician's court. So thank you all. Sorry for eating up 5 minutes of dental. Yeah.
This was actually a difficult case, and yeah. So this was actually a difficult case. So over the time, he progressed very suddenly after he was diagnosed to have a disease. He worsened very progressively and continued to have infection. We tried to rule out all the sort of infection, and finally it was skin only which was the possible source.